referring to. Okay. All right, so we're not referring to Western figures anymore. We have our own data, and Dr. Nyawera Mwangi currently is head of, how would I put it? She's the Deputy Academic Registrar, KMTC. And Dr. Nyawera Mwangi, if you are ready, take us away. Teach us many, many things, please. Thank you.
Thank you very much, Dr. Oscar. I am right here, and please confirm that you can hear me well.
Yes, I can hear you. We're just all here.
Okay. Thank you very much. So here is my screen. So welcome everyone. I am Dr. Nyawera Mwangi. I am at the Kenya Medical Training College, and we'll be discussing our research work, what we have found in about the diabetic retinopathy services. Here I'll use the word DR for diabetic retinopathy, and our research has mainly been geared towards finding solution for the gaps in our research. So I'll take you through context, aim, methods, and results of research. I will use DSG. This is what those observations mean. Now, first, the context.
We're losing here a
so
bit.
Diabetic retinopathy is.
I think something about your net. We're losing you on the sound a bit. It's breaking off a bit. Just proceed, I guess, but I'll keep you posted if we can't hear you.
Of public health importance. Any better?
It's okay. Just proceed. Yeah.
Okay. So everyone who is living with diabetes is at risk of DR, and once they develop DR, they are at risk of visual impairment and blindness. So this is what a simplification of what happens with diabetes. One is likely to have persistently raised blood glucose if the diabetes is not well controlled, and that affects many organs in the body. And for our interest here, it's the retina, the eye, the back lining of the eye is affected, and you get diabetic retinopathy, which now in turn might lead to blindness. So the main problem is the persistently raised blood sugar, that is hyperglycemia. What it does, it affects the small blood vessels of the retina. We get microangiopathy. Two things can happen. Either the vessels can be occluded, leading to ischemia, hypoxia, and eventually that provokes neovascularization. We can also have leakage of the blood vessels, and that will lead to retinal edema. So basically in DR, you will end up with retinal edema and also neovascularization. And these two may lead to visual impairment and blindness. So if you examine the retina, this is how normal retina would look like. And once you have neovascularization, you have proliferative DR that would look like this. Now, who is at risk of DR? We have said everyone who has diabetes is at risk of diabetic retinopathy, and the prevalence of DR increases the longer a person has lived with diabetes. So let's say within diagnosis, within 3 years of diagnosis, about 15% of the people with diabetes, this is any type of diabetes, will have DR. If you go on 5 years, 10 years, 60%, 15 years, 80%. So the duration is a very important factor. Of course, it's non-modifiable. So we need to know what we do, since once somebody has lived with diabetes, we know they're at risk of DR. Now, the typical patient in our country who requires DR services is from a low-income background with no insurance, attends diabetes clinic 3 or 4 times every year, but has inadequate awareness of DR and the need for services for DR. Most of them have never had a screening examination for DR, and I will show some data on that. We often see them with advanced stages of DR, and at that time, the cost of treatment is higher than if we had gotten them much earlier. So this is from these publications. So what do we need? We need a strong health system for diabetes and diabetic retinopathy so that all the people with diabetes can have the services that they need for DR, starting with screening, and then when they need treatment, they can get it. So we need a stronger health system. Okay. Now, what happens if we get a stronger health system? We will then increase access, utilization, and quality of health services. That is what you would expect in a strong health system. Then for visual impairment, we expect that fewer people will get visual impairment, and the healthcare costs for the individual, for the facility, and for the country would go down. So if we have a strong health system, we may get these benefits. What is the aim of our study? So our aim was to assess DR services in Kenya and to design strategies to improve DR services and to test those strategies. What methods do we use? So this slide summarizes the things we did. Is that first we had a health system assessment for diabetes and diabetic retinopathy. That helps us to identify the gaps and the strengths. After that, we had need for health system strengthening. This is about developing national guidelines for DR and also developing an online training course, which is now available. We also developed an intervention that is called Dure intervention that we'll be talking about. So we developed it, we tested it in a pilot study, then we implemented it as a full scale and evaluated it. And I'll be telling you about that. What are the results of this? So first, the results of the health system assessment. Now we did this in 3 counties. So we did in Kirinyaga, which is predominantly a rural county. We did that in Nairobi, and we did that in Nakuru. We took that because we have a rural, we have semi-urban, and then we have a fully urban area. So we looked at the services within diabetes clinics and within eye clinics to see how the health system works. So what are the gaps that we found? The main gap is that of all the patients that are engaging with diabetes services, already attending the services, only 24% have ever been referred for screening for DR. Okay, 24% only have been referred. Those who have ever had the screening were even less, so only 13% had ever had a screening for DR. So clearly, there's a problem with access or utilization of screening. We know the Ministry of Health recommends 100% of all persons with diabetes get screening, but at that time, which was 2016, we found only 13% had had a screening, and therefore we needed interventions that can address the 87% unmet need. The predictors of taking a screening exam, the main predictor was found to be referral for eye examination. So those who had been referred were 20 times or 21 times more likely to attend a screening exam. And those who had knowledge of diabetes eye complications, that diabetes can cause visual impairment, and that you need screening, those ones were 3 times more likely to attend screening than those who did not have this knowledge. So these 2 were the most important predictors. What are the barriers? Some of the barriers were lack of knowledge on diabetes eye health and a misconception that you do not need to attend screening until you have ocular symptoms. Okay, so most people were waiting for ocular symptoms before going for a screening examination. Lack of referral and also lack of clinical guidelines. These were the key barriers, and therefore we needed to develop an intervention to address these barriers. There were also strengths that we could leverage on. One strength was that we have community resources, that is the diabetes support groups, and diabetes services have already been using these support groups to link people to diabetes services. However, the eye care services, we have not previously been using PA support groups. So we can use them, we can leverage on that to increase uptake of screening. We have opportunistic screening services available various places in the country. We have high stakeholder interest, okay, among the community with diabetes, among diabetes services, eye care services. So this is a good opportunity to strengthen the services. And we already have task shifting already in use, and I'll be describing how that is relevant. So health system assessment helped us to identify the barriers and the strengths to leverage. And for more information, you could read this paper. Next, we also needed to do health system strengthening, and as well as the Dure intervention. So I will now tell you about these two, beginning with the health system strengthening. So those two are interventions that we did to improve diabetic retinopathy services. Now, so on the supply side, supply of the services, we needed to strengthen the health system to improve service delivery so that patients get the services for DR. If they visit either a diabetes clinic or an eye clinic, they can get services. So we needed to ensure the services are available, because there would be no need of increasing demand if the services are not available or if they're not good quality services. Then on the other hand, we also needed to increase demand, because we have seen that most of the people with diabetes have not had a screening exam. And the intervention we tested to increase demand is peer support, use of peer support to increase uptake of screening. So first, the health system strengthening. We developed clinical guidelines for screening and management of diabetic retinopathy in Kenya. And we also developed a training course for health workers on the control of visual impairment and blindness from DR. So first, the guidelines. They are available and they are already being used in the country. To understand the process that we use to develop those guidelines, we have this paper here to give you insights on how we did that collaboratively. As we can see, very many people were involved in this process. So this is guidelines as they are. We have on this link on the GOK, the Ministry of Health website. They are here and you could easily download them. These guidelines apply to all people with, hold on. They apply to all patients with diabetes who are 12 years and above, and they are for screening, diagnosis, referral, management of DR. Okay, so they are targeted for use by people at the primary eye care level, at the secondary level, and even at the tertiary level, whether they're clinicians or whether it's the policymakers, administrators, who may all work together to increase services. And we hope by using these guidelines, all persons living with diabetes will get a screening examination at least annually or more frequently if needed, and they will also get the other treatment that they may require. What do these guidelines recommend? They recommend that diabetes and eye care services should work closely together, because we realize that DR is not particularly an eye care problem, it's a diabetes problem. But we need to work together, diabetes and eye care services. All health workers providing DR, providing diabetes services, again, should raise awareness on DR, because they see the people with diabetes. And similarly, all people who are providing services for DR should also talk about diabetes. As I've mentioned, it recommends annual screening for all persons, and this is to be done by health workers. Now, at the lowest level of our healthcare system, at least a health worker can use a checklist to identify whether a patient has had diabetes and then has had DR and refer them for screening if they have diabetes. Then where screening services are available, the screening should be done by a trained person and should consist of at least two things. One, a retinal examination, and two, a visual acuity. So from that process, we have an electronic version of the guidelines. We also have print version that is being used in various facilities. We have training slides that are available. We have published these recommendations in journals. We also have quality assurance guidelines. We have mapped DR services in the country. We have also collaboratively developed IEC materials for both patients and clinicians, and we have monitoring and evaluation tools that are being used to monitor the implementation of the guidelines. Now, beyond that, this process has also been applied in other countries. So having finished this task, a country like Ghana has asked us to assist them to develop similar guidelines. And therefore we have done that. And they are in the final stages of producing their guidelines based on the Kenya model. The other health system strengthening activity was the development of a short open online course on control of diabetic retinopathy. This is available on this link. It's a short course that has 4 modules. It talks about the disease, the patient, the healthcare provider, the health system, the key gaps in those areas, and what barriers we might find related to these areas, and therefore what should be done. So this course is online, flexibly available to all persons in any part of the world. Okay, and how was this course developed? There was a program for UNESCO, Open Education for a Better World. So this is a mentoring program run by UNESCO to develop online courses or online materials so as to address SDG 3 and other sustainable development goals. So we involved a lot of technical experts and educational experts in the development of that course, and it's available online. So this is how the interface appears on the course, and it's available. You can have a look at it when you get time. Now, having talked about health system strengthening, which was a supply side intervention, we now look at the demand side intervention. To increase demand for DR services, what did we do? So here we use peer support to increase uptake of DR screening. And this is a cluster randomized trial called the DURE study, where DURE is the uptake of retinal examination in diabetes study. So what did we do? First, we had to develop the various components of the DURE intervention. And then we had to pilot test it, and then to implement it full scale once we identified that it was possible to run it on full scale. And then we did process evaluation to find out how and why it worked. And we also did outcome evaluation to find out its effectiveness in increasing uptake of screening. So this is a cluster randomized trial. We did this in Kirinyaga. You remember we had done health system assessment in 3 counties, and we found uptake of retinal examination was low in all, but the indicators were worst in Kirinyaga, and therefore we implemented this intervention in Kirinyaga. Okay, so conceptual framework for this study. So the DURE intervention is based on the self-efficacy theory. This is a well-known theory by Albert Bandura, used in sociology, in medicine, in other aspects, especially where we need to understand health behavior. So what the theory postulates is that health-seeking behavior, okay, is affected by self-efficacy. Before one can adopt any health-seeking behavior, for example, attend a screening examination, they need to have self-efficacy to do that. And what are the sources of self-efficacy? So we have four main sources: performance accomplishment, vicarious experience, verbal persuasion, and psychological cues. So if you want people to take up health-seeking behavior, you need to build their self-efficacy. How do you do that? You would have to address these four things. So if you want people to begin to take up a retinal examination, okay, you want them to start to initiate screening, okay, first, and then you also want them to maintain screening. So like in our case, most of the people had not had even one screening examination. So we needed them to initiate. Then we want them to do that every year. So what we need to do is to develop self-efficacy to take annual DR screening, and that will lead to initiation and maintenance. So we have to come back to these four items, and that is what we wanted peer supporters to do, these four things, so that they could build self-efficacy of the members of the support groups. So what did we want them to do actually? So peer supporters are members of support groups. These support groups are already in existence. As I said earlier, they already link their members to the diabetes services. Okay, now the peer supporters, we selected and trained peer supporters who already had a screening examination themselves. So what were they going to do? One, they were going to link persons with diabetes, PLWD is persons living with diabetes, to the eye clinic. So members of their support groups are going to be linked with the eye clinic. This involved referring them, sometimes involved actually taking them there or reminding them to attend. They also would share their own experience of screening, because sometimes people fail to attend screening because they are anxious, they're apprehensive about the experience. So for example, people are anxious about if they go for the screening examination, will they be able to see, will they be able to go back home, will they be able to walk, will they be able to drive? So how long will it take? So they shared their own experience, and that would make people develop self-efficacy. They also provided information on the screening service, where it's available, how much it costs, how much time, and so on. And finally, they provided information on vulnerability. For example, getting the members to know that they are all at risk of DR, because members of support groups are those who have diabetes, and they are all at risk. And they also help the members to understand the severity of DR in terms of there is risk of visual impairment and blindness. So these four things would lead to self-efficacy. So what we propose that if peer supporters do this, people will go for the screening exam and maintain it. And we postulated that self-efficacy is on that pathway. Okay, what are the methods of the DURET trial? So our methods are described in this paper. I'm not going into detail, but I'll mention a few things. So we said this was a cluster randomized trial. So we had two groups, an intervention group and a control group. So what happens with diabetes support groups? They have monthly group meetings where they educate themselves. They have talks about diabetes. They measure their blood sugar. They have glucometers there. They have a blood pressure measurements done there, weight, and so on. So they meet in various different places. Some of them meet in churches. Some of them meet in a dispensary. So this is the usual care. So both groups were going to continue with usual care. In addition, in the intervention arm, we're going to have peer supporters. These are people who have already had a screening examination. They're going to be trained. They're going to be trained to deliver the intervention. And what are they going to do? To give monthly group education on diabetes eye care. Already the groups are giving diabetes education. Now we wanted them to give information of diabetes eye care. They were also going to refer individuals for screening. So they would refer them verbally as well as give them a card, a referral card. We had a particular referral card which they gave to the persons to go for a screening exam. So this card was like in three, like the way you have a triplicate. So the patient or the member of the support group was given a referral, okay, that had two parts. One part would remain with the doctor upon screening, okay, and the patient would keep one. And then the peer supporter had also the other copy. So it was possible to track that process. Then they also gave monthly telephone reminders to those members to go for screening. This study was for a period of 6 months. So every month, monthly group education, every month, monthly telephone reminder to those who had not yet taken a screening examination. Okay. Okay, what are the results? Okay, first we had the pilot study. I will not go into detail, but our results were here. We found it was quite feasible. Okay, then we measured the self-efficacy at the start of the study and at various points along the study. So what we found that in the intervention arm, self-efficacy increased, whereas in the control arm, self-efficacy remained the same. So there's some tools, other tools for measuring self-efficacy, and that is what we adapted. So this is what we can see, the before and after. So the control, in the control arm, self-efficacy remained the same, but in the intervention arm, self-efficacy increased. Okay. Then for the uptake of screening, okay, uptake of screening, these were all people who had never had a screening examination. So the green are those who eventually took up the screening examination. So we can see we had still some people in the control arm taking the screening examination, but we can see there are more people in the intervention arm taking the screening examination. Okay, so this is the 6 months of the study. So we have 180 days, and we had said we had monthly group talks. Okay, so let's see if at the first group talk, after the first group talk, we can see in the intervention arm, we had an increase in the number of people that took up screening exams. So 50% of the persons in the intervention arm, right after the first group talk, they took up the screening examination. By that time, only about 1% in the control arm had taken up the screening examination. Now, so 50% by month 1, and by the end of the 6 months, only 54% had taken up the screening exam. So we can see an early response, but also a ceiling effect. So these reminders, did not seem to increase the proportion of people that attended screening, but the first group talk or the first referral, the first reminder seemed to have been the most effective. In the control arm, we see there was just there was a small increase in the uptake, but that was gradual rather than sudden. So the early response and the ceiling effect can be seen. So 46% of the people still did not take up the screening examination. So 54%. So it's there is effect, but still there is quite those others who did not take up the screening examination. So the key findings are here. People in the intervention arm, okay, they were 5 times as likely as those in the control arm to take the screening examination. So this shows the effectiveness of the intervention. The maximum effect is within the first 1 month, early response and ceiling effect. And then we still need to think about the 46% that did not take up the screening exam despite this intervention. So these findings are soon going to be out in this paper in the Lancet. Now, how and why did the intervention work? Okay, so what made those who took up the intervention take it up? What about those who did not take it up? Why did not take it up? In order to understand how an intervention works, it's important to do process evaluation, which we have done, that's published in this paper. But what we found is that the main enablers, okay, for uptake was first the referral card. You know, you remember the peer supporters were giving their members a referral with the person's name, with the person's name of the support group, date of referral, and so on. So this referral card was highly valued. And even now, when I visit, when I visit the eye clinic there, I still find people coming with that referral card, and it was highly valued. Then the personal style and zeal of the peer supporters so influenced the intervention. So the support groups, they were in total 14 support groups. So we had 7 in each arm. So in the intervention arm, we had 7. The effectiveness was higher in some support groups than in others, which depended on a few things. One, the geographical distance of the peer support groups. Those which were nearer had a high uptake, perhaps because of proximity, but more importantly, the personal style of the peer supporter, the individual characteristics. So there are some peer supporters who adapted the intervention and even ensured they took every person to the eye clinic for screening, or they visited their homes to remind them. So the zeal of the supporters is important. The importance of highlighting this, that if this is to be scaled up, you know, it's important to identify peer supporters that can scale up the intervention in such a manner. The training of the peer supporters and the task shifting was also highly valued. So the peer supporters felt this was an important role that they were playing, and the fact that they received the training, they valued that. They kept on asking for the certificates, and their profile or their reputation was valued in the group, so that is important. The other aspect is the community entry. We went to the support groups through the umbrella association, which is the Kenya Defeat Diabetes Association, which was very important. Secondly, we went through the county, the chief officer of health and the staff at the hospital who have already been working with the support groups, and this was very helpful. Stakeholder engagement in both eye care and diabetes services, both at national level and at the county level, really helped. And the fact that we now had guidelines. So what has happened, the hospitals, once they have the guidelines, they have able to use the guidelines, for example, to influence supply of, let's say, the dilator eye drops that they need. And therefore the supply side interventions also assisted on the increasing the services and therefore the demand. Some of the barriers that still remain, we identified these from those who did not go for the screening examination. So most of the people in the intervention side still had intention to go, but they had not got. They cited cost. This is cost of the service, but also cost of transport, and as well as the opportunity cost, what they would have been doing that day that they are going for the screening examination, especially those who lived far. Geographical barriers and distance. So besides the distance, places which are more remote, the terrain is not good, and they take maybe more than one vehicle to get to the hospital, experience difficulties in access. So the location of the service you know, if we compare that to the population, the nearer the service, the easier for the persons to attend. Okay, so what we are saying is our intervention. Because of our intervention, 54% of the population of interest took up the screening examination, and they did that within 1 month. Okay, this can be scaled up so that we can do the same in other counties. But we remember also the 46% who did not take up the screening examination, meaning that there are additional barriers because they talked about having the intention to go, but they had not yet gone because of the barriers I've said. So we need also an intervention to address these post-intention barriers. So what we're saying is we need combined interventions if we are to reach our target of 100% of people with diabetes attending screening services. What are the implications? Is that we have an existing community resource. This is the diabetes support groups. When we began this work in 2016, we had about going to, let's say 30 something of the counties had support groups. They have since increased, and this is ongoing. So most of the counties have peer support groups, diabetes support groups. So this is a resource that has been quite effectively used in many places for diabetes services, and we can use it. This is acceptable. There is the peer support is acceptable because it's already ongoing, it's cost effective, and it's scalable and sustainable. So we could use this. So I acknowledge all those that funded or participated in this study. Thank you very much. I end there. Thank you.
Well, thank you very much, Dr. Nyawera. That was quite an enlightening speech. Actually, a lot of it just rings near home because these are homemade solutions for us. So we don't need to copy anything from anywhere. And I'm glad you're actually teaching people Ghana. You mentioned Ghana and other countries elsewhere. Maybe if I may just mention of note, the role of NHIF in the uptick in terms of screening and all, did you find anything in your studies if someone has an NHIF is more encouraged to attend eye care services, to come for DR screening, for example? Does that have any link? Does that help in any way? As I look at the other questions on the forum here.
Okay, thank you very much, Dr. Oscar. Yes, we did ask, what we were asking all our participants is whether they had NHIF, and then secondly, if they have used it. So what we found is that most of the people did not actually have the NHIF. They had not registered, they did not have it, and therefore it follows that they had not used it. So, but we went on to ask them to actually register for NHIF. Mainly, we were telling them that it would be useful, okay, in the screening and in the treatment. We also asked about this cost, because the cost of the screening examination in Kirinyaga, basically what they were doing is they were going to pay 100 shillings, so $1, 100 shillings. But okay, many of them could say, yes, I can afford, but the main problem was the transport, and the opportunity cost, and the fact that they will leave their work, maybe their wages or their farm work for that day. So the main barrier was the costs, the other costs, not the consultation, and then the treatment, of course. Yeah, thank you.
Great. Thank you very much, Dr. Nyawera. There is an anonymous attendee who, well, seems more of someone a bit unhappy there. You went so fast on the part of the basis of DR, especially the part of necrosis. Would appreciate if you'd elaborate that more, because that's actually the core of the topic.
The part about?
That you went so fast on the part of the basis of the, I think this is the pathophysiology of DR.
Oh, okay, okay.
The vaso-occlusive state, the sticky RBCs and all that. Just mention that, yeah, somewhere at the beginning there.
Okay. So I believe it's that slide. Am I screen sharing?
Yeah, sure, we can see that.
Okay, all right. Okay, I can have a go again and just say that, yes, we are saying who is at risk of diabetic retinopathy. It is people who have diabetes, whether type 1 or type 2, any type of diabetes. And we know in diabetes, we have persistently raised blood glucose. We, of course, would expect that people get to control, metabolic control for their blood sugar, but more often than not, we know that if you go to any diabetes clinic, when people come there, most of them are out of control. So at home, many people have persistently raised blood glucose. We also know most people do not have glucometers in their homes, so they don't monitor, and it is until when they visit the clinic that they get to do it. However, in support groups, we are seeing some support groups, people combine forces and they obtain a glucometer. That's why I was saying in support groups, although they meet like once a month, at least they get to test their blood sugar there. Now, persistently raised blood glucose affects many organs in the body. That is why people with diabetes will have kidney problems, they'll have problems in different parts of the body, including the eye. Okay, so in the eye, the diabetes affects many structures in the eye, but for this particular case, we'll talk about the retina, which is the lining at the back of the eye that is light sensitive. So once it's affected, you get a retinopathy, and that can lead to visual impairment and to blindness. And then in this slide, so first, the topmost photo shows a normal retina. If you examine the eye, see the retina that is there. So you can see there are blood vessels there. And now the bottom one is when we have proliferative diabetic retinopathy. You can see the pattern, the blood vessels are different. So what happens with persistent raised blood glucose? It affects blood vessels anywhere in the body. So the small blood vessels and the large blood vessels are affected. So the small blood vessels are affected. We have microangiopathy. So two things can happen. The vessel can be occluded, and when it's occluded, we get ischemia, and that will eventually lead to neovascularization. The other thing that can happen is that the vessel can become leaky, leak fluid, and we end up with fluid within the retina, retinal edema. So all those features are together, we can say they are features of retinopathy and maculopathy, and they will lead to visual impairment and blindness. So a screening exam involves an exam like this, where you look at the retina to identify any features of DR so that you can get early treatment. Next, I said, among the people with diabetes, okay, how does the prevalence of the diabetic retinopathy, increase with the duration of diabetes? So if you've lived with diabetes for 15 years, it's very likely you have some form of retinopathy. So 80% of people who have had diabetes for at least 15 years will have retinopathy. Okay, if you've had it for less, then, like at 3 years, just 15%. So the main thing of this slide was to show the longer you have had diabetes, then the more likely you are to have retinopathy. Yes, and we see these people in our clinics, and then this was what we're describing, that many of them don't have insurance, among these other factors. Thank you.
Thanks a lot, Nyawera. That was quite a detailed explanation on that one. More questions are coming in. Joy Gituma is asking, where is the DR screening done, and are there specific facilities in the counties doing this?
Excellent, thank you very much. So yes, in eye clinics, we have eye clinics. Let's say at every county, at least in every county, there's at least a hospital with the eye clinic. Now, a screening exam can be done at the eye clinic. Now, when you're at a diabetes clinic or at a normal clinic, what one can do, we have some checklists, and we have shared them across counties, where even if you don't have any equipment to examine the retina, or you're not trained to do that, you can ask the patient, have you had an eye examination for the last 12 months, because you want it to be monthly. And then that checklist allows you to refer the person to the nearest eye clinic. So whether it is a Ministry of Health clinic or a mission hospital, or wherever, it is an eye clinic, the person who is there should be able to examine. Now, we also did the mapping of actually these screening services, and we have provided that information in these guidelines, which can be downloaded. But take it that any clinic, let's say most of them are at county facilities, and some also at the sub-county. When there's an eye clinic, then this clinic can be done. I would like you to encourage all persons with diabetes to visit the clinic. Thank you.
Again, thank you very much, Nyawera, for that. As we move along, Norbert Pesci is also asking something about most counties do not have trained ophthalmologists. We are still very low in number, and rely on clinical officers trained in eye care, but have no experience to identify DR and might not even have the fundoscope. I think for example, I don't believe they have no experience to identify DR, because you simply need to know how to do fundoscopy to identify DR. Then something about this, Mr. Norbert Peshu still asks, can you briefly discuss the care DR? Maybe your comments on what Norbert says, if about not having trained ophthalmologists in the counties, but what do you think about that?
Okay, thank you. So yes, we have ophthalmologists. I think in recent times the number has really increased. So I would say in most counties there is an ophthalmologist in the public sector, and also they're there in the private sector. However, screening does not actually require you to be an ophthalmologist. Okay, screening can be done even by non-ophthalmologists, because it's fundoscopy or using a slit lamp. And we even have places with a fundus camera. So a fundus camera does not even require you to be a medical person. A technician can take the fundus photo, and they're trained as screeners, the people called screeners and graders. They're even non-medical people, but if you have a fundus photo, they're able to identify the features. So the way to go is to have the service available, not peg it to the ophthalmologist. Again, because there are many services, like including treatment, surgical intervention. There are things that would be done by the ophthalmologist, but there are also things that non-ophthalmologists can do. So in particular, screening examination can be done by others, but they are trained. So like the OCUs, even ophthalmic nurses, and the technicians I'm talking about, as long as they are trained, then they can do it. Thank you.
Yeah, thanks, Jawera. And just to add on to that, I believe all counties have an ophthalmologist currently. Yes. And anybody who really wants to know more about the DR screening can simply, every county there's an ophthalmologist, and then now is when you work with the OCOs and the cataract surgeons who are there. And it will not be difficult to identify who can help you or not. But there is hope, and these are homemade solutions for us. There's something about, briefly discuss the care DR, or not care DR.
Okay. So the care of, I believe the person means the care of a patient with DR. So thank you, a good question. So the first thing is to remember this is a patient who has diabetes. So first, we need to manage the diabetes. So like control diabetes using the various treatments that are used in diabetes. Many of them may also have hypertension. So you would also control hypertension. They may also have other complications of diabetes, not necessarily eye problems. So those also have to be managed. Now, when we have DR itself, it can be early, it can be late. So the key thing is to detect. Early detection is important. And once you have early detection, you can control the blood sugar, control the risk factors like the high blood sugar, high blood pressure. So one aspect is controlling the risk factors. Then number two, regular monitoring to see if there is progression. And three, timely treatment. This might involve laser treatment, or it might involve anti-VEGF treatment, or it might involve surgery. So there are various things. It depends on the stage. So the most important thing is prevention, then early detection through screening, and then timely treatment using any of those modalities. You can add, Dr. Oscar.
Okay, that's very true. Early screening, early detection makes it easier, whether you're going to inject antivascular factors, whether you're doing laser, or it's a conservative management. But the key word there is early screening processes, and that's what we're talking about. The other question that Norbert had asked about, it's possible to also have telemedicine aspects. Remember, the mobile phone is also being used now to do fundoscopy, so it is something that someone can work with. I mean, we get pictures being sent to us on WhatsApp or Telegram, and you can still help and advise someone on what to do. And again, using a mobile phone, I remember one of the we have people who are non-medical, as you rightly said, who are doing very good, clear fundus pictures and sending sending it to the ophthalmologist, and that works well. Now, moving along, there's a mention of, there's a question by Bernard on the prevalence of diabetic retinopathy. What is the prevalence of diabetic retinopathy among the diabetics in Kenya and the whole of Kenya? I believe this is in the guidelines. All this information is there, isn't it, Dr. Nyawera?
Yes, all this is available in the guidelines. Nevertheless, I can make a comment about it.
Okay.
We first of all, about the prevalence of diabetes. I think we had the national stepwise survey, which found that about 2% of adults 18 to 69 years in Kenya have diabetes. But 50% of them do not know that they have diabetes. So it is undiagnosed, but they are walking around with diabetes. That's an important thing. Then for DR, it is known that a third of people with diabetes at any given time have some form of DR, a third of them, 33%. And then again, another third have vision-threatening forms of DR, so they need immediate treatment because they are at risk of visual impairment and blindness. So good to know. A lot of people have diabetes and they don't know about it. Even if they don't know about it, they're still at risk of DR. So you would say any person who is diagnosed of having diabetes, even today, any adult, needs to also have a screening examination as soon as possible and then regularly. Thank you.
Okay, great. Thanks, Dr. Nyawera. It's all wonderful stuff, and we're learning a lot today. Dr. Kahaki has mentioned, basically alluding to seeing patients with advanced diabetic retinopathy, yet they're being seen by the physicians and not sent for screening on time. She suggested using something similar to the MCH booklet with boxes ticked for various disciplines so that nobody falls through the cracks. What do you think about that?
Yes, I absolutely think it's quite right. Like we said, we had found only 24% had ever been referred. And then we actually had a talk with the diabetologists and to find out why is it that they don't get to refer. And one of the things that they were saying, diabetes has so many complications. And sometimes the checklist is so long, the things they have to remember. So sometimes people remember the kidney, but don't remember the eye. Secondly, even the patients sometimes are more worried about the kidney and not the eye. And then sometimes you refer the patient, but they don't get to go to the eye clinic. And when they come back, it's not easy to remember to ask them if they went. And it is for that reason that we then had the checklist where anytime a person comes to the clinic, they can be reminded to go for the screening examination. So I agree, a booklet would be good to have that information. So what we're doing is to work very, very closely with the diabetes clinic so that we see among the people who are attending it, at least they all get the screening exam. Like at Kenyatta, at least good enough that there is the camera in the diabetes clinic. So everybody coming to the diabetes clinic gets the father's photo, and those who require treatment, they are then taken to the eye clinic, but also we share the data so one can tell of those who came to the clinic in a particular month, how many of them were found to have DR, how many were referred, and then the data in the eye clinic, did they actually go? So it's a way to go to work together with diabetes services. If of course we could have more funders, cameras, very good. But clearly we need to use the resources we have. I feel, yes, the booklet would be a good idea. Thank you.
That's a very good idea. And then such fora like what we're having now also sensitize. I'm seeing we have over 600 participants in this. That's also a way of enlightening people and informing people that DR is real and it causes blindness. So I think this is also a good thing to attend for everybody else to know what's going on. We have an anonymous attendee asking about symptoms of DR. Basically, the two questions can be imagined to symptoms of DR and blood.
Okay.
Someone who's lost the ability to see with one eye. Symptoms of DR. I mean, what happens in terms of vision?
Okay, thank you very much. The first thing to say is that there may be no symptoms. So symptoms are a late feature in DR. largely this is asymptomatic. So if we wait for symptoms to develop, by that time, then already to be in the late stages. Then the symptoms may not be very, very specific. So, and they may not be dramatic. So for example, one might just notice some spots in the eyes, spots in front of the eye, or broad vision. There are none that are very, very specific for DR. Importantly, it's often painless. Mostly it's painless, and most people are waiting for pain to develop. It's painless, or for redness to develop. Those symptoms may not be there. So the key thing to say is that one, even if you have no symptoms, you could still have DR, so you need a check. And two, if you develop any symptom, then you also need to have a check. Thank you.
Very good. The screening, as you mentioned earlier, annual screening is a must for all diabetic patients. I mean, you're talking with or without symptoms. And then along the way, because by the time you're starting treatment, we don't know how long you've had the hyperglycemia. Okay, so you started treatment, could have been there for years, months, and the changes could have started by the time you're starting treatment. There's also a question from Alexandra. Are you in a position to share the DR screening chart and checklist? I believe this is in the guidelines, isn't it, Nawera?
Yes, it's in the guidelines. And it's also, different print copies are also available from ophthalmic services unit. So they're available from ophthalmic services unit, and from myself or from the website. So they're downloadable, they're available.
Okay, great. So simply, whoever is interested in getting the guidelines gets in touch with you.
Okay, yes,
okay.
Absolutely.
Okay, great. I'm seeing with the questions. Okay, lots of accolades there from Dr. Kahaki. There's a question on CPDs, which I believe Dr. Kinuthia will answer in due course along the way. Now, I'd wanted to ask about the online DR training. Is there any cost to it? And you said, I think you said, is it a 3-day program? Or what is that about again?
So thank you. So first, it is free. It's completely free, and it is flexible in your own time to do it. So really, there are no special restrictions in terms of time, and so we have videos, we have text, and we also have links to additional documents. So I think it's some people might be able to run it quickly, some others might want to take some time to look at it. So I would say there's no standard timing, and there is no limitation, and no cost to it. Thank you.
Okay, super. I'm looking here, I'm not seeing anything more. Would you have any closing remarks, any take-home message after the wonderful talk you've given us for the last hour?
Thank you very much. Yes.
What point did we carry home tonight?
Yes. So thank you for attending. So the key thing we want you to take home is that there is something you can do to prevent one more person from losing their vision from diabetes. So what is the thing that you can do is that anybody who has diabetes, or anybody who is at risk of diabetes or has a higher risk of having diabetes, they need to go for a check. Okay, so I've said many people may have diabetes and may not know it. So it's good to have first a check for diabetes to check whether you have diabetes or not. That's available at any nearby clinic. And then if you have diabetes, it is important to have an eye check. Okay, have an eye check as soon as possible. And then after that, the doctor will advise you when you need to go next, but everybody must go at least annually. Now, let me also say that a few times we discover diabetes in the eye clinic. So a person comes to the eye clinic, they are examined, found to have features of diabetic retinopathy, and they did not know that they had diabetes. So that is how they get to know they have diabetes. So still good to have an eye check. And when you go to the eye clinic, ask, I want to have a check for diabetic retinopathy, because there are many different types of eye checks, but please mention that you want to check whether you have diabetic retinopathy. And that way you will help many people. And then the other thing I want to say is, again, encourage people to have NHIF. Diabetic retinopathy can be a very, very expensive disease, so that if you're going to have injections with anti-VEGF, it's very, very expensive. I have a patient who was telling me that it was costing them 40,000 to 60,000 per an injection. So it helps to have NHIF, whether you have diabetes or not. Thank you very much for attending the session.
Yeah, well, actually, we have some, we like to say, late bloomers. There's a question on, are the guidelines being rolled out at county and sub-county level? Once you have it on soft, I believe you just need a contact person there and you send it on WhatsApp or email or something. Are you rolling out the guidelines across the counties and sub-counties?
Yes, okay, we are rolling them out to the counties and sub-counties as much as possible. But of course, since we have them online, you do not need to wait for them to reach there. If you just Google guidelines for diabetic retinopathy in Kenya, you will be able to get to download it. So you don't have to wait for it to reach you in that other way. And if you need any other information, you can always reach us. Thank you.
Wonderful, Nyawera. Super good stuff. Finally, this is a parting shot. Where is DR in terms of blindness, as causes of blindness in Kenya? Is it top of the list?
Okay, thank you very much. So like anywhere else in the world, the leading causes of, the 5 leading causes of blindness, one can actually, for visual impairment and blindness, they are easily named. So cataract remains the leading cause of visual impairment and blindness, and cataract again is treatable. So any person who has visual impairment or blindness can be treated if they have cataract. As another cause is uncorrected refractive error, so which can be corrected with simple interventions like spectacles or other interventions. We have infectious causes like trachoma, which is now going towards elimination. It was previously a leading cause of visual impairment and blindness, and other causes of corneal blindness like trauma. And then you come to diabetic retinopathy. So if you're listing the 5 or 6 leading causes, you will get to diabetic retinopathy. Thank you.
Okay. Thank you very much for a very enlightening session, Dr. Nyawera. I want to wrap it here at this point. I've learned a lot today and hope to definitely run and meet you along the corridors and we exchange more ideas.
Thank you very much. Thank you.
Okay, have a good evening, everybody.
Okay, bye. Thanks.